Good morning, everyone, and welcome to the first session that we have on Frontiers TBI 2020. I'm just going to introduce Amy Jolly, who will be chairing the session. Amy is a postdoctoral researcher at Imperial College London, working on developing remote cognitive assessments for dementia patients as part of the Dementia Research Institute. So Amy, if you'd like, take it away. The floor is yours.
Hello, good morning, everyone. Can everyone see and hear me now? Just pop yes in the chat if you can. So thank you very much. Welcome to the Behaviour and Cognition session. So we're going to be getting started shortly. Just a few kind of bit of information for you. So today, if you'd like to ask a question to one of our speakers, you can see at the bottom of the tab there's an Ask the Question tab. If you have a click on that, you can type any question you're interested to ask the speaker into there, and I will make sure to keep an eye out on those. If you see a question that you think is really good and you would like me to try and ask the speakers, please do just upvote that question. You can see a small arrow above the number of votes next to it. Top questions I will try and get presented to the speakers as much as possible. Just a bit of information. So the talks today will be 20 minutes, followed by 5 minutes Q&A. So please, if you do have a burning question, pop it in there for me. So without further ado, I think we will start with our first speaker. So our first speaker is going to be Professor Karen Caeyenberghs. She's a psychologist and a neuroscientist. Her research interests are focused on the mechanisms underlying neuroplasticity in brain-injured patients, and she uses a multidisciplinary approach which spans behavioural sciences and the cognitive neurosciences, with a specific focus on the study of the brain structure and connectivity using medical imaging technologies. So she's contributed to a wide range of different interesting studies that I personally enjoyed, including paediatric TBI, and she's also been developing novel home-based training programs, which I believe she will be covering with us today. So Karen, if I can just pass it over to you, and thanks very much for joining us.
Yeah. Hi, everyone. Hi, colleagues. It's good evening from Melbourne. I will start sharing my screen. I hope it's working. Is that working, Amy?
Yeah, we can see that. If you just pop that into slideshow, that should pop up the full screen. Thank you.
Okay. Good morning, everyone. It's a very weird experience, this virtual meeting, but happy to join this meeting. And first of all, I would like to thank Amy and David for inviting me to give a presentation during this fourth Frontiers in TBI conference. The program looks amazing, and I think it will be a very productive virtual meeting. So today I will present a critical review of evidence for training-dependent structural neuroplasticity in TBI patients. So more specifically, I will really try to focus on the relationship between behavioral improvements and neuroplastic changes. So in one of my previous studies, we found that there was an improvement on the digit span backwards in young TBI patients after a computerized cognitive training program. And this improvement coincided with a decrease in mean diffusivity of the left SLF2. So in another study, we found significant positive correlations as well between increases in FA in the cerebellar peduncles and improved performance on postural control tests. So although these results sound very interesting and promising, we really have to be aware that these relationships only explain around 30% of the variance, and they're actually only weak to moderate relationships. And it's also very important to note that most of the neuroplasticity studies actually did not find any significant correlations. So today, I really want to talk about this missing link between behavioral improvements and structural neuroplastic changes. I think to really get a better insight in this relationship, I think we first have to tackle some issues. And today, I will present a few of those issues. So the first one is that I think we need to come up with better behavioral tests, and we also have to use more advanced models for the operationalization of dependent variables. The second thing is we really have to think about the training program as well that we give to our TBI patients. And the third thing is we have to rethink again about the structural MRI metrics that we use in our studies. And then after tackling all these issues, maybe the issues are just related to our TBI patients. So the first thing that I want to mention is in one of my previous training studies, we used this setup, which is called the Neurocom. It looks like a torture setup, but it's, I can reassure you, no children were harmed. It's an instrumented measure of postural control. So it enables to test balance under different sensory conditions. And so we found significant improvements on 2 subtests of the Neurocom in the TBI patients that received the training, but also the healthy controlled children that received the training. And we really have to be a bit critical about our own work, because although we find these significant improvements, these tests on the Neurocom really resemble the training tasks that they underwent during their training program. So for example, in one of the training tasks, they were instructed to follow this river by moving their center of pressure to the right and the left. So we can actually only talk about near transfer effects. And I think we really have to take a step further and administer far transfer tests. So really by looking at the level of the activity and the level of the daily life participation of TBI patients. So in one of our studies, we used the activity-specific balance confidence scale. And with this questionnaire, we can really tap into the balance confidence of the patients. So they had to respond how confident they felt to not lose their balance during a list of daily life activities. And interestingly, we really found a significant improvement in this balance confidence. So they really showed a significant increase after 2 months of balance training. And interestingly as well, during one of the test sessions, one of the TBI patients mentioned to me like, after doing this balance training, I was finally able again to go for skateboarding with my friends again. So I think future training studies really should examine whether there are any improvements in their daily life participation. And I think we can obtain these far transfer effects by changing our training programs. We really need to move towards multimodal training programs. I think we need to move away a bit from training programs that only focus on one behavioral function. For example, the Cognition training program, it's a commercially available training program, but it actually targets only one behavioral function. So we have recently developed a novel training program called Cogmo. The name says it all. It trains different cognitive functions together with upper limb functioning. So it actually consists of one big touch screen and tangible user objects. And so in one of the games called Pangles, the participants have to match the colored lines on the screen by rotating these tangible user objects. So it's clear that these games really target different functions at the same time. It requires mental rotation, puzzle solving, and hand function at the same time. It's also important to note, so task difficulty also increases with better performance. And a final note as well, that it's important to mention that no research assistants were harmed during the making of this video. So if you're interested in this novel training program, I want to refer to a poster by Adam and Phoebe. They will present later today. And then I also want to emphasize that we should move away from these single test points. We have to administer ecological momentary assessments to really get better insights in the daily dynamics of cognitive impairments. So our lab has recently developed a novel app called DCAM, and it includes 4 brief cognitive tasks. So it taps into working memory, inhibition, attention, and processing speed. So by administering these brief cognitive tasks on a daily basis for a month, we can really obtain within subject variability in cognitive functioning. And besides cognitive tasks, our app also includes questions from well-established questionnaires. So these questions tap into stress, anxiety, pain symptoms, and so on. And this can really enables us to examine the mediating effect of emotional well-being on cognitive functioning. And so our pilot results, so this was only in healthy adults, but the results are very promising. So with this data, we can run random effects models. So we can really look at the level of the individual patients. And every colored line represents one subject. So for example, you can clearly see that, for example, we found significant positive relationships between fatigue and reaction time on the perceptual speed matching task. So the more fatigued the participant, the higher the reaction time. And this brings me to my next topic as well. We should try to employ more specific behavioral measures. We can do this by running more advanced models, such as the drift diffusion model, which enables us to disentangle reaction time in different components. So besides just looking at reaction time as a whole, we can now look at the visual non-decision time, we can look at the actual decision time and motor execution time. And so one of the dependent variables of this drift diffusion model is the drift rate. So that's the rate of information accumulation that drives this decision making process. So higher drift rates denote faster information accumulation. And in our data in healthy controls, we found that the drift rate, as expected, is higher in the congruent and the neutral trials of the local global task compared to the incongruent trials. In our balanced training study, we extracted fractional anisotropy and mean divisivity of the cerebellar peduncles in our young TBI patients. And we focused on the cerebellum because we know it's important for postural control, but also the cerebellum has been implicated as a region where there's lots of indirect damage after sustaining a TBI. So we found significant changes in our tensor metrics. However, it was an increase. We found a significant increase in mean divisivity in the inferior cerebellar peduncles in the TBI patients that received the training. So this was a bit unexpected at first sight. However, it's due to the nature of the structural MRI metrics. So structural MRI metrics, including diffusion MRI metrics and BBM and free surface metrics, they're very sensitive, but they're not specific. For example, for the diffusion MRI metrics, if you see or if you observe a decrease in FA value, this can be due to many factors. So it can be due to the fact that there's a loss of axon density, or it can be due to the loss of myelin. Or another scenario is that the brain region is just with crossing fibers. And this was probably also the reason of our increase in MD with the balance training. So a few solutions that I want to suggest for future studies is that we really have to move away from this tensor model, and we should try to apply more advanced models of diffusion. And if you do have time, I know our scanning time is very expensive and it's very precious, but we should try to administer more specific additional MRI scans. So with regards to the first bit, advanced models of diffusion, there's this recent framework called pixel-based analysis. And this framework actually gives you more specificity. So it enables us to calculate fiber density, which is a measure of the microstructure of the fiber bundles, and a measure of fiber bundle cross-section, which is which is a metric of the macro structure of the fiber bundles. So we have used this framework in our young TBI patients. And in the first analysis step, we actually compared a group of healthy controls with a group of young TBI patients. And we really found significant reductions in the 3 Fixel metrics widespread. So we found significant decreases in fiber density of up to 50% in, for example, the corpus callosum and the fornix. The decreases in the cross-section were less extensive, but still noticeable, so they were also significant. So we found decreases in the superior cerebellar peduncles and cerebral peduncles. And we also found a decrease in the combined measure. So what we did now was actually we were interested to see whether training could restore these alterations that you observe at the pre-test. So can we see changes with balance training in these alterations? And for this, we used a small Fixel mask correction, a very difficult term that we invented, but it's just a small volume correction. And interestingly, we found significant increases only in the fiber cross-section. So it seems that training can restore the macro structure of the fiber bundles. And more specifically, we found these increases in the left lateralized sensory motor regions. So yeah, I would definitely recommend to use this framework and try to move away from the tensor because it can really gives us more specificity to the results. Then in our other training study, this was a working memory training study. We administered the high angular resolution diffusion imaging, which enabled us again to apply an advanced model of diffusion. This time we used the chart model, which gives you a measure of axon density. But this time we had some time left, so we acquired the McDespot. And this scan gives you a more direct measure of myelin, including the myelin water fraction and the relaxation rates. And of course, we had a T1 scan as well. So what we did in the study, we actually had a palette of structural MRI metrics, and we used these metrics as adjuvates in our graph theoretical analysis framework. For this study, we actually focused on one measure of graph theory, and we focused on a measure of global integration. And more specifically, we calculated the global efficiency, which is inversely related to the path length. So the higher the path length, the lower the global efficiency. So this metric really just denotes the number of paths that you have to cross to go from one node to another node. So interestingly, after this working memory training study, we found significant increases in global efficiency in the group that received a high complexity training regime. And on the other hand, we found significant decreases in the group that trained at a very low level of task difficulty. This was a very surprising result. But then when we compared the sensitivity of the different adjuvates, very interestingly, we found that it was actually the R1 of the McDespot scan that seemed to be most sensitive to pick up these training-related changes in global efficiency. And then on a further topic related to global efficiency, I really want to emphasize as well that we should try to move towards the use of more specific network metrics. So in one of the meta-analyses that our PhD students run, we actually found that the characteristic path length seemed to be the most robust graph metric across all the graph studies in TBI. So this was only with regards to diffusion MRI connectome studies. However, most studies actually interpret these changes as, there's a disruption in communication, or there's a change in information processing speed. However, these statements are a bit too bold. We really have to tone these statements down because how you calculate characteristic path length or global efficiency is actually by using the shortest path algorithms. But these have very unrealistic assumptions. So, for example, they claim that every node has to have a global roadmap of the overall network, which we know that that's biologically not plausible. So in the future studies, we should use navigation algorithms, which are more realistic and have more biological plausible assumptions. So FiTBI has run she has used these specific network metrics. And interestingly, we found significant positive correlation between navigation efficiency and the drift rate on the incongruent trials. So again, the higher the efficiency of the structural network coincided with a faster information accumulation. So my message of my presentation is really that we should try to move towards the use of more specific behavioral metrics, but also using more specific network metrics. And only by doing that, we can get a closer relationship between brain and behavior. So when we used the characteristic path length, we did not find any significant correlations. Then finally, I want to talk a bit about the TBI patients as well. As this is a TBI conference, I'm guessing that most of you have received this comment during rebuttals or revisions of papers or assessors on your grant applications. It's a very common comment that we receive on a daily basis, that how did we account for heterogeneity in our TBI patients? I think the answer is actually that we should embrace heterogeneity by actually looking more at the individual level of the patients. So we have done this successfully by using a mathematical framework, which is called the network diffusion model. So this model uses atrophy data of the free surfer output on one hand, and the healthy connectome data of the diffusion MRI data. So we were able to identify brain regions of where neurodegenerative patterns likely originated. And it's interesting to see, because in this pilot data of 17 patients, it's immediately clear again that it's of high heterogeneity, because the number of epicenters of injury were varied widely. And at the same time, the anatomical distribution of these regions also varied widely. And then at the same time, we also are working on some studies where we try to see whether we can use graph metrics at the individual level. And we are even including our new specific measure, the navigation efficiency. So if you're interested in these spider plots, again, Adam and FiTBI will talk about this in their poster number 6. And then finally, we are all aware that most of our TBI patients have focal lesions. And I have ignored this for a long time as well by excluding TBI patients with large focal lesions. However, I think we really should move towards embracing these holes in the brain and try to come up with a good protocol. So this is something that we're trying to do with our colleagues from the Enigma brain injury working groups. We're actually trying to come up with an advanced lesion mapping and brain parcelation procedure. We have our protocol in place, and one of the steps is this semi-automated lesion delineation step, where we really try to obtain an accurate lesion map. And that's the end product that we use in further analysis as well. So we use this lesion map in our connectome analysis, in our diffusion MRI analysis, and the network diffusion modeling. And then at the same time, we also have an advanced lesion mapping workflow where we try to examine the impact of these lesions on the white matter networks and on the functional networks. And there will be a presentation by Nick as well at 11 a.m. UK time. And he will talk a bit more about how to deal with these large focal lesions when you have resting state fMRI data. So if you're interested, you can listen to his Blitz talk and look at his poster as well. So just to conclude, so as a take-home message, is actually a bit of a question. I think, can we get closer to the relation between neuroplastic changes and behavioral improvements? I think the answer is yes, but there's also a big but. I think we really need to try to implement multimodal and multidisciplinary training interventions in future neuroplasticity studies to really obtain these far transfer effects. We really have to utilize more specific structural MRI metrics, but also don't look away from your behavioral metrics. I think we have to reconsider to use more computational models like the drift diffusion models to obtain more specific behavioral metrics at the same time. And then we should not ignore the focal lesions anymore or just focus on patients with diffusion injuries. We have to come up with a good protocol to deal with these large focal lesions. And then finally, besides analyzing large-scale data sets, I think we also can move towards individual patient-level analysis. Of course, all this work would have not been possible without all my team members. I would like to thank the funding of NHMRC, and I want to thank all my colleagues from the Enigma brain injury working groups, which I think there are lots of them online as well. And I would like to thank you for listening to my virtual presentation. Let me know if you have any questions. Thank you.
Thank you very much, Karen. That was a fantastic presentation. Very, very interesting stuff. So in the interest of time, I'm going to just ask one or two questions, if that's okay. So we have one from David Sharp here asking, do the training benefits you observed transfer to non-trained tasks? And what is the best way to try to generate transfer of benefits?
Yep. So yeah, so just from my own experience, it's very hard to obtain these far transfer effects. And I think the lack of far transfer effects is mainly due to the nature of the training program. I think the majority of studies are always trying to examine like a training program that really focuses on one behavioral function. We really have to try to come up with more multidisciplinary training programs because we know that the symptoms that TBI patients experience, it's a lot of symptoms. So you have to try to tackle all of these in a big training program.
Fantastic, thank you. And we've got an interesting question here. Someone was just wondering, could you discuss the relationship between structural connectivity and functional connectivity?
Yeah, so I want to refer to the work of Nick. He will talk later, but that's something that we want to tackle as well. So we are trying to use multi-layer networking to really get a better insight in the relationship between structural and functional connectivity. Because this was something that I want to get as another issue in my talk as well, that I've noticed that sometimes the relationships between behavioral improvements after training are more often observed with fMRI studies, because I think with structural MRI, it's probably going to be more a non-linear relationship, but it would help to get into this relationship between structural and functional and link that back to behavior, but I'm not sure yet how to examine a relationship with the behavior on that, on the other hand.
I think you and I are both in that situation with some of our research. So yes, I understand and feel that. Karen, thank you so much for your time today. It was a fantastic talk. There is a Slack channel, so if there's more discussion that wants to be had, please do head over to that if you're still interested. And I'm sure Karen would be happy to answer any further questions by email or by Twitter. So thank you very much, Karen.
Yeah, thanks, Amy. Thanks again. Thanks for listening.